السلام عليكم. The clinical day. First scenario, Mr. John Smith, 60 years old, came with complaint of tummy pain. Please take history, examine, and address his concern. Are you ready, Dr. Ayan?
Yes, doctor.
So we can start. Here you go.
Hello, my name is Dr. Ahmed. I'm one of the doctors in the clinic today. May I confirm that I am Mr. John Smith, 60 years old?
Yes, Doctor, I'm John.
Nice to meet you, Mr. John. Today I'm here to ask you some questions about your health condition. I will need to examine you and answer your concerns. Is that okay with you?
It's okay, Doctor.
So can you please tell me how can I help you today?
Yes, Doctor. Actually, you know that last 2, 3 months I have some pain in my tummy. And initially I thought that maybe it will improve. I take some painkiller medication, but I feel it's not improving. And I feel also there is some my bowel passage is not properly now working. Sometimes there is some loose still also coming. So I am worried about that condition.
There is what? Sorry, doctor, your voice is a little bit not clear, honestly.
There is some loose stool with tummy pain. So I'm
Loose
worried
stool.
about this condition. Yes.
I'm sorry for your suffering, Mr. John. I'll try my best to help you. Do you need any painkiller at the moment?
No, it's okay.
So let's start with the tummy pain. You said it started around 2 to 3 months back, isn't it?
Yes.
And when it started, was it sudden or gradual in onset?
I feel initially it's slowly started, but nowadays I feel it's more actually.
Now it's more. Okay. Where is the pain exactly?
I feel there is in the left side. Actually, in my whole tummy there is a pain, but sometimes it's left, sometimes it's right.
Hmm. And do you feel it going anywhere else, for example, to your back?
No, I don't feel like it that.
Okay. And what's the nature of this pain? Is it dull aching pain, sharp pain,
I feel there is some compression pain, pressure
compression
like
pain,
pain. Yes.
pressure pain? Okay. And on a scale from 1 to 10, how would you rank this pain?
It's like five, around five.
Hmm. And is this pain continuous over the past 2 to 3 months, or does it come in attacks?
Actually, as I said, initially it's sometimes coming and going, but last 1 month I feel it's most of the time I have pain.
Mm. And have you noticed anything makes it worse? Any type of food, any certain movement?
Not significantly. Sometimes due to heavy food it causes more, but not significant.
Heavy food can cause it worse?
Yes, sometimes it's worse, but it's not significantly food related.
Mm. What about anything makes it better?
No, I don't feel actually.
Okay. Have you seeked any medical attention for that? Have you seen any doctor?
Yes, before I seen by doctor, they said it's maybe my tummy infection. They give some antibiotic. I feel little better.
You were
After
given.
that, it's yeah, they give me some medication for infection. But after that, it's again happened. It's initially it's little improved, but later again it's continuous pain, like that problem.
When was this when you were given medication for infection?
Like 2 months back.
Okay. And before these 2 to 3 months, were you completely normal?
Before actually there is a sometimes I have some loose stool, but it's not something significant.
Okay. Now tell me more about the loose stool. So are you getting the loose stool for the same duration, 2 to 3 months? Or you said
Yes,
before
I feel
also?
that.
So it
Yes, no,
getting. Mhm.
yes. Last 2, 3 months I feel more.
Okay. And can you describe it for me? Is it like a watery type of stool or is it pale, bulky stool?
Yes, doctor. Actually, it looks like water initially, as I said, like 2, 3 months. But nowadays, last 1 month, I feel there is some blood passing with that. So
Blood.
now I'm more worried. Yes,
Mm. Okay, I'm sorry for that. And how often do you pass stool per day?
like it's 4, 5 times now.
4 to 5 times?
Yes,
Okay, and how much is the blood? Is it a huge amount or
not
minimal
huge
amount
amount.
strict? Mhm.
It's mild to moderate.
Okay, and is the blood, sorry to ask you, mixed with the stool, or does it come before or after the stool?
I feel it's mixed actually with the stool.
Okay, and is it fresh blood?
It's mostly fresh, yes. So far I understand it's fresh.
Do you pass any clots?
I don't see actually clot.
Okay, and do you have any pain while passing the stool? Like pain in,
Yes,
down?
no, not
Not
down. I feel in my tummy.
okay. Any slime in the stool?
Not significant, very mild.
Okay, is it difficult to flush?
No, it's okay, flushing.
Okay, after passing stool, do you feel relieved with the tummy pain or no?
No, no, I don't feel.
Okay, how are you compensating this loose motion?
Actually, I'm trying to take more fluid, water to compensate it.
Hmm. Okay. Do you have any past medical history I should be aware of?
Yes, doctor, I have diabetic and high cholesterol level, but it's mostly controlled. I'm taking metformin and atorvastatin.
Metformin and atorvastatin. Okay.
Yes.
When was the last blood sugar check? Like 3 months blood sugar check?
Yes, it's like 6.5, like that. 6.57,
Okay.
like that.
Okay. Can you show me your medication list?
Yes, as I said, metformin 2 times and atorvastatin 10 mg
Are you
1 time.
compliant to medications?
Yes, I'm taking regularly.
Okay. And are you taking any other medications or over-the-counter medications?
No,
Okay. Any recent travel?
no,
Any sick contacts?
no.
Any raised body temperature?
Sometimes I feel my temperature little raised, not significant.
Uh, since when? Also 3 months?
Yes, it's like 1 month, 2 months like that.
Do you have any chills with it or night sweating?
No,
Any weight changes?
I feel, yes, doctor, you are right. I feel my weight changing actually, doctor. I lose my weight.
How much did you lose over how long?
I feel like last 3 months I lost almost 10 kilo.
Hmm. Um, okay. Any, was it intentional?
No, no, it's not intentional.
What about your appetite?
I feel tired, feel little poor appetite.
Okay. Any lumps or bumps anywhere in the body?
I don't feel, but I feel there is some swelling in my neck.
Swelling in your neck. How many
Yes,
how many swellings do you have?
there is a two swelling in my two side of neck.
Okay. Are they changing in size or number?
No, no, the same number.
Okay. And do you have any weather preferences?
No,
Any fatigue? I mean, like tiredness?
yes, as I said, you are getting tired, losing weight.
Hmm. Okay. Anyone commented that you are paler than before?
Yes, somebody said that I look little pale than before.
Are you losing blood from anywhere else apart from your back passage? Like
No,
throwing up blood or bleeding under the skin?
no.
Any yellowish discoloration of your eyeballs?
Yes, doctor, somebody said I look little pale and something yellowish coloration of my eyes also.
Hmm. Okay. And do you have any headache?
Due to tiredness, I feel this headache.
You have headache, you said?
Yes, yes, I feel a little headache, maybe due to tiredness.
Okay. Any dizziness
Not much.
or dizziness when standing from sitting position?
Yes, it's sometimes because you know that I'm not taking properly food. Maybe there is a reason. That's it.
Okay. And about the headache, where is it exactly?
It's diffuse in my whole head. No,
Does
any part of it.
Is it at a specific time of the day?
No, no,
Does it increase with coughing, sneezing, bending forward?
no, no,
Any change in your vision?
no, it's okay.
Any weakness in any part of the body?
No,
Any problems with sensation you're feeling?
No.
Any joint pains?
No.
Any skin rash?
No.
Any soreness in your mouth or soreness in your private area? Sorry to ask you.
No.
Any cough or coughing of blood?
No.
Any chest pain?
No.
Any shortness of breath?
No.
Any awareness of heartbeat?
It's okay.
Any swelling in any part of the body?
I feel my tummy is little distended before.
Distended, okay. And any change in your water work or frothiness or change in the color?
No. Not okay.
Okay, and have you done any surgeries in the past or procedures?
No.
Any history of blood transfusion?
No.
Any family history of a similar problem or family history of cancers or any family history of note?
Actually, I heard that my grandfather maybe died from cancer, like in the tummy. Exactly, I don't know.
Hmm. Okay, and can I ask you some personal questions?
Yeah, sure.
Do you smoke?
It's occasionally.
So I advise you to stop smoking as it's dangerous to your life. And if you need help, we can refer you to smoking cessation clinic. Is it okay with you?
Okay, doctor, thank you.
Do you take alcohol?
Yes, doctor, I'm taking actually alcohol much.
Much. Okay. How much do you take?
I feel it's 20 units per week.
Actually, Mr. John, this is too much for your health and it actually can affect your health in a bad way. I advise you to moderate your alcohol intake. Is it okay with you?
Okay, doctor, I'll try.
Okay. And I'm sorry to ask you, do you share needles?
Yes, doctor, a long time back I traveled there. I took some needle sharing, sorry to tell you.
When did you share needles? Sorry?
It's like 6 months back. I went for traveling. There, I take some recreational medicine to the needle. One time
6
I
months
taken
back.
it.
Okay. Okay. Apart from that, any tattooing or piercing?
No,
And do you have any partners?
I have a regular.
I'm sorry to ask you, any casual relationships?
No, not a regular.
Okay. And what do you do for living?
Actually, I'm retired. It's a work as a clerk.
And do you drive?
Sometimes.
Okay. Is this affecting your driving in any way, the dizziness especially?
Till now, actually, I don't feel.
Okay. Can I examine you, please?
Yes, sure.
I want to check the vital signs, especially the blood pressure sitting and standing.
Blood pressure 110/70, no postural hypertension.
Okay.
Pulse rate is 100, normal volume. Temperature 37, RBS like 8.
General appearance of the patient in cachexia,
It looks
jaundice.
like yes,
Hmm?
there is a yellowish coloration of the face and trunk. I
Okay.
shared the picture.
Okay.
Let's see that.
I want to check
You can
the.
you can
You send
talk.
the
I'm
picture?
sharing
Yeah,
picture.
I will.
You
Okay,
Two
I
can
want
minutes
to
talk.
left,
check.
but I will add for you 1 more minute, Dr. Ryan, okay? Because it's complicated
I,
case.
I will examine the hands for any digital clubbing, any um, like depotrans contracture, flapping tremor.
Then, no flapping tremor, but there is a like icteric, like little yellowish coloration of the hand. I
Okay.
shared the picture.
Any palmar erythema?
No,
Where you shared? Where? In
Yes, I am
the.
sharing it here
in the
now.
group.
Okay.
Now in the
Uh,
chat box.
no flapping tremor, huh?
No flapping tremor.
Okay. And what about the pulse? Is it a good volume, regular?
Pulse is 100 and regular and average volume.
Okay. Any scratch marks in the arms?
Yes, some scratch mark in the body
Okay.
and arms.
Needle sharing sites?
No needle sharing mark. Similar.
Okay. Then the eyes, conjunctival pallor, scleral icterus.
Slightly icteric,
Okay, temporalis wasting.
not much. As you
Par
show the picture actually says not coming properly, but not much.
Parotid enlargement.
No.
Okay, I want to examine the lymph nodes in the neck and any
Yes.
supraclavicular lymph node. Yeah, positive.
Yes. Yes. Small cervical lymphadenopathy, both sides. Slightly hard.
Okay. Okay. Any spider nevi? I think there are, yeah, in the chest. Okay.
Yes.
Axillary hair
What
loss.
is
Okay.
what you see in the picture, like same.
Okay. Now I want to examine the abdomen.
Mm.
Warning the patient, then superficial palpation and deep palpation, any tenderness, any organomegaly.
Slight tenderness in the right side, right upper part, and left lower part. And also you saw there is the abdomen is slightly distended.
So I want to check for ascites.
Yes, it's shifting dullness is positive.
Okay. I want to examine.
Mild ascites.
I want to examine for bruit, any bruit over the liver.
Liver, yes. Liver, it's confusing. Its sound is not clear, but you can sound there is a like two finger breath hepatomegaly.
Okay. And is it regular, smooth service or irregular?
Yes, it's not
Smooth.
like irregular. Yes,
Okay.
normal.
Okay. I want to check the legs for any swelling.
Mild pitting edema.
Okay. What are your concerns, Mr. John?
Actually, what happened with me, doctor? Why I have this pain and this diarrhea?
I highly appreciate your concerns, Mr. John. I have a few possibilities in mind. I think the main problem is related to the alcohol intake that you took a lot and the sharing of needles. This is most likely has affected your liver, most likely led to a problem in your liver. It could be an infection or could be something else. But this has led most likely to liver failure. We need to run some blood tests and we need to run do some scans, and we will involve a group of doctors. Of them is the gut doctor, the liver doctor, and we will manage you accordingly. Is it okay with you?
It's okay, doctor, but I'm thinking, doctor, is it cancer? Because I'm losing my weight, I feel tired, I'm worried.
So, honestly speaking, Mr. John, cancer is a possibility that we should exclude in your case. So we have to check for that.
Okay, doctor.
Any more concerns for me?
No, it's okay.
For the time being, Mr. John, I advise you actually to stop your alcohol intake because it's directly related to your condition, and also stop smoking, and also to stop the sharing needles. And if you develop any severe vomiting of blood, severe tummy pain with fever, please let us know.
Okay, doctor, I need admission.
Yes, we will admit you.
Okay, doctor, thank you.
Thank you, Mr. John.
Yes, time is up. You can start now and then I will send the proton beam.
Okay, so what is your finding, Dr. Ryan, and what's your differential diagnosis?
So I examined Mr. John, who is presenting with 2 to 3 months history of tummy pain with loose motion and bloody especially. He has tiredness with pallor and jaundice, and he has history of sharing needles and heavy alcohol intake. He's non-diabetic with cholesterol and family history of cancer. On examination, he has tachycardia, soft blood pressure, scratch marks on the limbs. He has conjunctival pallor, scleral icterus, spider nevi, like stigmata of chronic liver disease, spider nevi, loss of axillary hair and chest hair, abdominal. He has ascites and tender hepatomegaly, and leg swelling. So my top differential is most likely chronic liver disease, could be due to infectious hepatitis or like hepatitis C, or could be alcoholic liver disease. or could be other like causes hepatocellular carcinoma. And we need to rule out also spontaneous bacterial peritonitis in this case. That's it. Hello?
Yes, doctor. Actually, I want to know that what about your concern about my tummy pain and loose stool? Because my main concern is loose stool, diarrhea, blood, if there is a tummy pain. This is my main complaint.
Actually, I was thinking that the tummy pain could be related to the spontaneous bacterial peritonitis, and the loose motion could be with the bloody stool, could be from like the varices due to liver.
But I don't have any esophageal, I mean, no mouth bleeding, only rectal bleeding.
Yes, you
Esophageal
are
there is
right.
supposed to be mouth bleeding. Okay, how will you investigate this case?
I will run basic investigations, full blood count with differential and ESR, CRP, renal function panel, liver function panel, and viral serology, hepatitis C, B, and coagulation panel, and iron profile with ferritin. And patient might need also scopes, upper endoscopy or lower endoscopy. Also might consider ECG because he's anemic and with dizziness.
Okay, how will treat this case?
Also might need acetic tap. How to treat this case? Non-pharmacological disease education and counseling, and multidisciplinary team approach, including GI doctor and hepatologist, specialized staff nurse, smoking cessation, and moderation of alcohol or stop alcohol if there is like evidence of liver failure, and treat the underlying cause with it could like related to the if it is infection, we will treat the infection. We might need biopsy with surgical resection accordingly.
Surgical. Okay, so if I asked you that, as you found it's a chronic liver disease, tell me two cause of the chronic liver disease in this case, and two cause
In
of
this case,
this bloody diarrhea in this case.
Of chronic liver disease, I told it could be an infectious
Yes.
hepatitis, like hepatitis C, or alcoholic liver disease, or hepatocellular carcinoma.
Okay, and if regarding that bloody stool,
honestly, I cannot think of anything because you said there is no vomiting of blood.
okay, thank you, doctor. Thank you.
Thank
Okay,
you for
doctor.
the good case.
I'll comment or Dr. Vasim will
Difficult one.
comment.
Yes, this kind of subject, what I give. It's enough. The case already complicated enough.
Very complicated.
I'll comment. I'll comment or Dr. Vasim will.
No,
Both of
Dr.
you.
Veer, you first.
You comment and
Okay.
Dr. Basim.
So, okay. So see, here patient coming with diarrhea. My main concern is diarrhea with tummy pain. And as I said before, I have watery, but I now feel actually there is a bloody diarrhea. So this is bloody diarrhea, and bloody diarrhea with feature of the chronic liver disease, with right upper abdominal pain, with hepatomegaly. What are you thinking? Bloody diarrhea with chronic liver disease. What do you think, Dr. Dayal?
Um,
And patient is losing weight, tiredness, weakness, anemic jaundice. So this is actually ulcerative colitis. Ulcerative colitis is associated with that
at this age?
primary
At this age?
sclerosis.
Or you are hiding
Yes,
the
ulcerative.
history?
No, I
Oh,
said you that I have 3, 4 months. I had some loose skin, but that time I'm not concerning. I took some medication, and I thought maybe it's a simple infection, but I'm not improved. Okay,
why in
so
such
now
old age?
actually it's 60 years. It can happen. It's not like that. I think it's not like that uncommon that 6 years it will not happen.
Mm, okay.
And also now actually that is a liver involvement as I saw that there is some jaundice and also there is some liver tenderness, also hepatomegaly, and patient is losing weight. Because if I want to keep it say, as a carcinoma, I have to give little
So,
older age. You understand, like patient is losing weight. So primary sclerosing cholangitis, ulcerative colitis can associated with that colon carcinoma, can
mm,
associated with the hepatocellular carcinoma, and patient has history of family history of carcinoma. As I said, there is a grandfather, there is history of the carcinoma in the tummy. So that's why actually I need to keep like 60 years I keep because I want to keep this history to the carcinoma. Okay, so it can associate it with the hepatocellular carcinoma, can associate it with that colon carcinoma, and also patient has family history. And your history taking is nice, your examination is also good. But actually, I think that you are not concerning about my main complaint and not also concerning about the investigation purpose of that my diarrhea with blood stool. So you need to some tests for blood stool, colonoscopy, sigmoidoscopy, like ulcerative colitis, you need to rule out. IBD ruled out. Also need to do some stool tests like microscopic culture, that one, and also for primary sclerosing cholangitis associated with that. So MRCP, ERCP you need to do, and basic blood tests like liver function test, it will be abnormal. And still maybe there is some infected agent can come, and also calprotectin, fecal calprotectin, and you can found in my blood there is a anemia. And also you can do ultrasonography and CT scan to rule out that colonic carcinoma, like for any structural disease. So that's why these are the related, all are related, like ulcerative colitis, primary sclerosing cholangitis can cause hepatocellular carcinoma, can cause colorectal carcinoma. And I
mm,
think, and after that, as you know, that you have to go for non-pharmacological approach, non-pharmacological, stop the alcohol, and also then social support and patient education counseling, bowel doctor you need to involve. That's what that, actually, ultimately, that primary sclerosing cholangitis, the ultimate treatment is liver transplantation, but you can give some supportive treatment as there is some pruritus, cholestyramine, ursodeoxycholic acid, and also regarding that ulcerative colitis, you know that ulcerative colitis that there is some topical agent, topical bisalagine, topical steroid is not improved, IVF steroid, and even not improved, then go to the monoclonal antibody, like a stepwise. So we need to treat both of these cases. But ultimately, liver primary sclerosing cholangitis, the ultimate treatment is liver transplantation. That's right. And also, yes, Dr. Basil said, also there is a surgical approach, like colectomy, ileoanal pouch, colectomy surgical option. That's all my comment.
Yeah, thank you, Dr. Tanvir. It's very nice case, and it's a very nice case to be trained on before exam for two reasons. For the short as abdomen in the short station, chronic liver disease and the finding of chronic liver disease, and as long for ulcerative colitis or liver disease. It has two topics. You cover two topics in this scenario. The chronic liver disease or finding or stigmata of chronic liver disease, along with the ulcerative colitis and cancer. So my opinion, Dr. Ryan did well, but she was lost in between. I don't know why you talk long, Dr. Ryan, asking about the pain itself. I think 3 minutes analyzing the pain. I prefer to not to exceed 2 minutes for the complaint. Because once you exceed these 2 minutes, it will waste the time and it will take from the time of the system review or the consultation symptoms. You ask the consultation symptoms later and the past medical history later, which if you ask earlier, it can save your time. This is what I prefer always. Complain, you have to analyze it within 2 minutes, not exceeding that. And after that, the constitutional symptoms, past medical history, then relevant system. Here you have to ask all questions for GI. You ask them, but I think you ask them late, related to the jaundice, the pallor, mouth sores, difficult swallowing, the tummy discomfort. You have to ask about tummy discomfort, especially in the right area. This is expected to be for the liver or hepatomegaly or cancer, as here, as in this case, primary sclerosing cholangitis or the cancer in the gallbladder. And the other question for melena, blood, change of the bowel habit, the criteria. I believe this case is very complicated. The diarrhea itself also need to be analyzed. And you did it. You analyzed the diarrhea and you reached to its cancer or cancer-related diarrhea. So it's watery with blood, and you can relate it to the original disease in this scenario, which is ulcerative colitis. But I don't know why you didn't suspect cancer. You have positive constitutional symptoms. Yes, you can think about HIV, hepatitis, because there is risk habit. But cancer, with any family history of cancer, you have to analyze it more. You know that, or you got that there is positive family history of cancer colon. You have to ask at what age. Any family history of other cancers. You have to apply here Amsterdam criteria. If this patient's father or any family member with age of 50, you can either throw out or throw in cancer colon. Again, cancer colon, one of the possibility, although there is cancer in the liver or hepatocellular or cholangiocarcinoma, whatever, but there is cancer in this patient. You have to put it in the top. You said there is chronic liver disease related to that alcohol, and in the alcohol history, you didn't stop his alcohol. You have to stop his alcohol. He is taking a lot, and still he has chronic liver disease, so you might stop him from alcohol. Okay, you have to advise him to stop alcohol totally, not to moderate. This is related to the clinical communication in general. Okay, so let's talk about skills. In this patient, it's a case of exam. You have to train. If you have partner, train yourself to do such cases, hypertension cases, diabetic cases, and like this chronic liver disease or ulcerative colitis, diarrhea complicated by this case, primary sclerosing cholangitis. You have to train how to take history and to examine such complicated case. You have complicated cases always in the exam, not simple case with no finding or minimal finding. Such case, it might come in the exam, and you have to finish a history within 9 minutes maximum. You have a lot of finding to examine in the examination. So related to clinical communication, I guess you cover everything. Although you talk long time, but you cover everything. For the examination, you examine, of course, but you exceed the time. You picked up a lot of findings. You ask about every complication of stigmata of chronic liver disease, which is perfect. So you can get all marks good in this. But for the concern, you didn't put the cancer at the top of the possibility. Although he asked you, but you have to put it. He had B symptoms or constitutional symptoms positive. The appetite is lost. You have to put the cancer in the top. Don't wait for him to tell you, do I have cancer? Okay. So this is also, it will harm your mark in the concern. The clinical judgment, I think you cover it well. The differential also, you put the cancer, one of the possibility. Although you didn't think about the case, like what Dr. Tanvir gave to you, like ulcerative colitis complicated with cholangiocarcinoma, but still you can give it as a differential. For the welfare and concern, I guess the welfare here will be minus because you didn't advise to stop alcohol totally, which is one of the exaggerating factor, and it might worse the liver. The
Dr.
other thing,
Basim,
yes,
she did stop him from alcohol. In
no,
the
no, she
end,
said moderate.
in the
In the
end,
end,
she
she
told
stopped.
him,
Okay, no
yes,
problem.
she told him, I told you to moderate, but I advise you to stop
Okay,
alcohol completely
okay,
and
good.
stop smoking.
Maybe
I
I
was
didn't hear
waiting
this
for
well.
her. I was waiting for her.
Yes,
When she
perfect.
did
If she
that,
did,
I was very
okay, yeah,
happy.
perfect. Yes, yes. It will be satisfactory if she did that. But the first time she said you can moderate your intake, which is still inadequate in this patient. Okay, good. The other thing,
Sorry, excuse me.
yes, yeah,
Just regarding the alcohol, I think better idea to refer the patient to alcohol nurse because you may, if the patient has excessive alcohol abuse, he may have alcohol withdrawal symptoms, and this will affect him. So generally, what we'll do, we refer the patient to alcoholic nurse. So she and you advise the patient that if he need to start alcohol regime, the role of the alcohol nurse, she first advise the patient. It's not advising. She take a full history of alcohol, and if he's like alcoholic, if the patient is alcoholic, that means he need regime to decrease the alcohol intake. Because they didn't stop alcohol
Yes.
suddenly at
I
all.
agree with you, Doctor.
Okay,
Yeah.
that's why I think I will not advise like stop alcohol, but I refer to alcoholic
Yes,
nurse,
I agree. Thank you, Dr.
so
Mayla,
they will
for
start that.
yeah,
Okay.
thank you for your comment. But always, I used to say that, but in the comment during discussion with the patient, of course, you will not say, I need from you to stop it directly. Like what we are doing with the smoking. If you are willing to stop, we can refer you to the smoking cessation clinic. Like the same here. If you are willing to stop, we will refer you to alcohol lesson clinic or services. So I mean, while we are talking, yes, I'm saying you have to stop him, but it's not the way you are talking to the patient. In the talking way to the patient, you have to say to him, I can help you to stop it or gradually stop it, or I will refer you. The same as referring patient to smoking cessation clinic. But this is the comment as a clinical judgment at the end. It's not the way you are talking to the patient. You got it, Dr. Mayada. But thank you for the clarification. You have to refer, of course. But I need from her to say that to the patient. If she say already yes, but better to be in the same way Dr.
Okay.
Mayada mentioned. Yes,
Yes, I get
yes,
you, but this is
yeah,
very
yeah.
important because here in this country they took the every single word
Yes, you're
the
right. You're
doctor
right.
say very seriously. Like if you said like alcohol, stop alcohol, they stop alcohol, and the patient will
Yes,
come next day with alcohol withdrawal symptoms or whatever. That's why you didn't need to mention this to the patient. Don't
yeah.
mention to him that stop alcohol. So
Um,
alcoholic nurse, she will come
Dr. Bassem, sorry, you are
inside the
sharing your screen.
hospital, and
Okay, no
she
problem.
assess
I'm
the
checking my
patient.
internet because there is some
So
connection.
referral is you will admit the patient to the hospital. Me, I
Yeah,
have
yeah, I
connection
think there
problem.
is some. I can hear some
Are you
interruption,
hearing
but
me?
maybe from my internet. No, no, no. Go ahead. Maybe from mine.
Echo.
Yes. Okay, go ahead. Go ahead,
Okay.
Dr. Mayada.
So
Continue.
generally now the main things are for the. Okay. So the main thing that you did for this patient, you admit the patient to the hospital. And when you admit the patient to the hospital, one of the things that you do, you ask the alcoholic nurse, you tell the patient about the plan, but this is one of the important part of the plan. So alcoholic nurse, she will come and she
Dr.
will
Mayada,
take alcohol history. There is a lot of criteria for alcohol history, and after that she will put a plan. They will start him a lot of things. So the discussion with her, when you admit the patient and you don't know exactly the secondary are you
yes, but there is some breaking in your sound. Please check your
hello
connection. Yes, yes, we can hear you, but there is breaking in your sound.
now okay now my sound is
Yeah,
clear.
now, okay. Yeah, 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 clear
Okay.
now. Okay.
So what I'm saying that this is patient in the first thing that you admit the patient to the hospital at the moment. So one of the plan that I refer you to alcoholic nurse. So what is the job of alcoholic nurse inside the hospital? She will sit with the patient. She put all the alcohol type and the units of the alcohol and the type of alcohol, and then she decide whether this patient alcoholic or not. If he is alcoholic, she will put him in diazepam and the regime, because you anyway you admit this patient to the hospital, and if this patient is alcoholic, inside the hospital he may develop alcoholic withdrawal symptoms. So that's
Exactly,
why
yes.
alcohol nurse is very important part in assessment of alcohol in any patient abusing alcohol.
Yes, you're right.
Okay. And even
Yeah.
when they start the regime of stopping alcohol, this is not our roles generally. Will be discussion with the nurse, not
Yes, exactly.
with
Yes.
the doctor. Okay.
Yeah. It's a good point to mention. Yes, thank you, Dr. Mayada. But I think be smart while advising the patient how to advise him to withdraw or to stop either smoking or alcohol. But the best way is to refer him. Tell him if
Yeah.
you are willing, we can refer you to the to special team. That's it. But don't say I need from you to stop. Yes, exactly. You will not stop him abruptly. Yes. Thank you, Dr. Mayada, for the clarification.
All right.
To
Thank you.
yeah. We should advise to reduce. No, I think with any liver disease, Dr. Tanvir, it's supposed to be stopped or withdrawal, gradually withdrawal. It's not reduce because already the
Yes,
liver is,
doctor.
yeah,
Yes, I understand. But as Dr. Maida what said, that as abruptly, suddenly
yeah.
stop, it can cause a
No, 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 not
so-called
abruptly. Yes,
withdrawal.
yes,
That's why we should say it for reduce, and also we will send to alcohol cessation clinic. So
yes,
they will
exactly.
reduce it gradually to avoid that alcohol withdrawal syndrome and
Yes, yes,
like that. Yes.
yes, exactly. Okay. Thank you, Dr. Tanvir, for the case. It's very nice case. Again, Dr. Ryan, you have to train about such cases. It's common in the exam. You have to know how to take history quick with target questions, especially with the positive like diarrhea, how to analyze diarrhea quick and also analyze the pain and of course the constitutional. Here you catch a lot of finding which is amazing, like scratch mark, the axillary hair, the gynecomastia. Everything you did in the examination was good. Even the history, you ask him, do you have jaundice, or someone told you you're having yellow eyes, and anyone told you you are paler. You catch a lot of things, but still the time you have to manage your time well. Okay, this is my advice. Anyone has comment or advice, Dr. Ryan? But in
Thank you.
general, you did great, Dr. Ryan. Really.
It was a
Any
good
question?
case. Thank you all.
Yeah.
And thank you for the comments the doctors gave.
Okay.
I really like your approach. It's very nice. It's a very nice
Yes.
approach. Generally, whenever you approaching the patient in a way that's safe, you are a safe doctor, yeah, it's okay. You will pass your MRCP. My consultant is MRCP examiner, and he keep told me that whenever they think that you are in the trap, so they will pass you. So don't worry to catch the diagnosis apart from the way you approaching the diagnosis. Okay, that your way,
Thank
I
you.
think, is perfect.
Thank you, Doctora.
Okay, let's move to the next scenario. Mr. James Carter, 48 years old with numbness in right foot. When you're ready, Dr. Tanvir, let's start.
Okay, just 1 minute.
Okay, take your time. I'll try to read the comments down there. She should stop him at the end. She did very well, actually. Yes, I agree, Dr. Tanvir. She did very well. It is a case of out of the box. He misdirected here by alcohol and sharing. Yes, you have to be ready for all these things in the exam. You might have a lot of finding in the history, either to distract you or to waste your time. So be smart. Try to finish all these questions as soon as possible. Jump to the examination. Ulcerative colitis has by model age, yes, of presentation 15 to 30 or 50 to 70. It is possible. Of course, it's possible. And BSS or BSC, primary sclerosing cholangitis, and cholangiocarcinoma might be in the elderly age. Should be some extra gastro manifestation, red eyes. Yes, you have to ask all these things. Family history, yes. Stool and examination, exactly, with the analysis. Cancer, colon, hepatic mets, this is my comment. Jaundice, hepatomegaly, ascites, Bat Chiari. I think Bat Chiari, it will be younger with a hypercoagulability status. So it's not the case. It will be acute within days, not within 3 months. But it's good differential, yes. But it will be more acute than this. Angiocarcinoma, of course, ulcerative colitis, exact. Okay. Yeah, as I wrote, the surrogate should ask her about the possibility of cancer. If she didn't raise it, he will raise it. But we should do it first.
Okay,
Okay.
Dr. Basim, I can
Yeah,
start. Huh?
yeah, let's go. Here you go.
Hello, I will start.
Yes, here you go. I reset the timer.
Okay. Hello, sir. I am Dr. Ali, one of the doctors in this clinic today. Can I confirm you are Mr. James Carter, 48 years old?
Yes, doctor.
Yes. So, Mr. James, can you tell me actually what happened with you?
Yes, doctor. Actually, I'm having numbness in my right foot for the past 3 days, and it's really bothering me a lot. If you can help me, please.
Okay, sure. I'm really sorry to hear that. I'll write some note and I'll take some history and later I'll do some examination. But because sure, it will be totally confidential, the note. Is it okay for you?
Yes, doctor.
Okay. Yeah, as you said that you have only right foot, there is a numbness, is it?
Yes.
Okay, can you tell in the which part of your foot?
In lower part of my foot, lower
Lower
part,
part
and
of.
yes.
Okay, so this is only in the one foot or also it's any other parts of body or in other leg or hand?
No, only my right.
Okay, so as you said, this is like last 3 days.
Yes.
Okay, so did you get any type of the trauma?
No.
Okay, this is happened first time or also previously you have?
First time.
First time you have. Okay, so how it's increased? Like, do you feel anything making it more increase this numbness? I mean, if you're walking or if you're doing something, that time you feel more this problem.
No, I didn't feel, but it's bothering me a lot.
It's radiating to anywhere from your right foot to anywhere.
No,
Okay, so with that numbness, how you compensate it? I mean, but do you, if you take some rest or any food or medicine, do you feel better?
no,
Okay, with that numbness, do you feel any weakness of your leg or foot?
no,
Okay, do you have any other complaint with that? Like you feel that your leg becomes stiff or foot becomes stiff, something?
no.
Okay, can I ask that do you have any long-standing disease before? I mean, diabetes or any other issues?
I don't have diabetes. I have asthma, and I
Mhm.
have allergic rhinitis.
Okay. What you are taking for your asthma and allergic rhinitis medicine?
I am taking s- salmeterol,
Mhm.
I think, and I'm taking inhaled steroids as well.
Mhm. How many years, or can you tell the duration, please?
Yeah, 6 months ago.
Okay, so you are complained with the medication. I mean, by using, you feel better.
I am not really feeling better, doctor. You know, last week I had an exacerbation of my asthma again. I get a
Mhm.
lot of asthma exacerbations over these past 6 months. And
Mhm.
every now and then they give me a short course of steroid oral. And last
Mhm.
exacerbation was last week, actually, when they gave me a new medication.
Mhm. What the medication name?
I think Monty Lucas.
Okay. So after that, now you feel better.
I am managing, doctor. Not really better, but I don't know. I am managing.
Okay. I'm really sorry to hear that. So currently, you have any respiratory distress?
No, I
I
am
mean, any
fine.
breathing difficulty now?
No, I am fine.
Okay. So can I ask that do you have any past history of surgery?
No,
Okay, and the similar condition running in your family,
no,
like
I'm
this
not
type of
sure.
numbness?
I'm not sure,
Not
no.
sure. Okay.
Mm.
What you are doing for living?
I am a teacher.
Okay. How much it's affecting your daily life?
A lot, doctor. Every now and then I'm getting these asthma exacerbations. And now for the
Mhm.
past 3 days, I'm troubled by this numbness.
Okay, I'm really sorry to hear that. So we can involve their occupational health worker. I think they can help you, and I will give you some sick leave paper. Is it okay for you?
Thank you, doctor.
Okay. Just I want to ask some personal question, if you don't mind. Do you smoke?
No,
Do you take alcohol?
occasional only.
Occasional is under the limit.
Yes.
Okay. Are you taking any other recreational medication or herbal medication?
No.
Okay. Mr. James, I just want to ask some other more question. So with that, do you feel that your weight is losing or you are gaining more weight?
No, I think my weight is stable.
You feel like pallor? Anybody said that you look paler than before?
No,
Any lump or bumping change in your body?
no,
Any problem with your mood? I mean, do you feel any anxious or depressed? Anything?
no problem with my mood, but I feel tired most of the time.
Most of the time you feel tired. Okay, so with that tiredness, do you feel like any headache,
No,
any dizziness,
no,
any problem with your vision?
no,
Okay, do you have any problem with like currently any blood productive? I mean, any blood coming with your coughing as you are asthmatic?
no blood, no,
Okay, any problem with your chest pain,
no chest pain. I just
heart
get the
racing
chest
between?
discomfort during the attacks.
Mm-hmm. Like discomfort mean what? Like pain
Tightness,
or burning sensation, tightness. But when you are taking medication and inhaler nebulizer, do you feel better after that?
a little better, not much.
Any heart racing beating?
No,
Any tummy pain?
no,
What about your back passage work, bowel work? Is it okay?
yes,
And what about your urine? I mean, water work? Is there any frothiness, any color change?
no,
Okay. Do you have any pain in your joint,
no,
in your hand, or any swelling,
no,
any skin rash?
no,
Any hot or cold temperature preference?
no.
Okay. And do you have recently any loose motion or vomiting? Anything happened recently?
No, just last week, this asthma exacerbation. That's it, nothing else.
Nothing else. Okay. And I just want to know that do you have any blood-related disease before? I mean, any blood clot or any blood
No, no,
issues?
no.
And can you tell me that how much steroid you are taking currently?
I am taking prednisolone 40 milligrams because of this attack last week. But I
Mhm.
should be finishing in like 1 or 2 days.
Okay. And as you said, you are taking frequently nowadays frequently given, is it?
Yes, I had attacks multiple times over the past 6 months, maybe 3 or 4 times.
Mhm.
So
And
every
how
time I get the attack, I take the prednisolone for 5 days.
for 5 days? Okay, and it's a 40 mg, as you said.
40, yes.
Okay. So, Mr. James, can I start examination for you?
Yes, doctor, sure.
Okay. So first of all, I need to check the hand. What about the vital sign like pulse, blood pressure, temperature, everything okay?
Normal, yes.
Normal. Is there any joint swelling in the hand?
No.
Any steroid purpura?
Any what, sorry?
Steroid purpura skin, any steroid purpura?
No, no,
Okay. Then I need to go for eyes. Is there any anemia or jaundice?
no,
Any mouth ulceration?
no.
Okay. I need to go for short examination like any tonsillitis, pharyngitis, anything associated with that.
There is pain at the sinuses if you offer to touch.
In the
Sinus,
face area, face
yeah,
area,
face.
maxillary area.
Yes.
Okay. Now I want to go for chest examination. So what about the chest movement? It's okay.
Movement is okay.
Okay. Then is there a trachea central?
Central.
Okay. And what about the auscultation finding? Like any crackles or wheezing, anything?
Wheezing is there, yeah.
Which part?
All over scattered wheeze.
Scattered which? Okay. I need to do other things, like I need to check that what is the tail? Process signs and chopstick sign. What about process sign and chopstick sign?
Negative.
Negative. Okay. Is there any parotid swelling or any facial appearance changes, any facial rash or any
No,
saddle-shaped nose?
no,
Okay. And what about the heart sound? Any murmur or the heart
no,
sound? Normal. Okay.
no,
Is there
yes,
any tummy
no,
tenderness, any part? Okay. Any organomegally?
no,
Okay. In the leg, I need to check that is there any stiffness or floppiness? I mean, tone and power.
normal.
Okay. So I need to check that joint position and vibration sense. Is that okay?
Vibration reduced.
Vibration up to which part?
Just in the big toe, on the left, on
Just
the
in the
right
big toe,
side.
right side,
Yes,
just in the big toe. Is there any swelling in the big toe?
no swelling, no.
Okay, then I need to go for a sensation test, like pin peak and touch sensation. What about the sensation?
Reduced in the right side,
Right, up to which part?
up to the ankle.
Up to the ankle. Okay, I just need to check also reflex. Is there any
Reflex is
reflex and
normal.
normal reflex? Can he do
Coordination
coordination? I
normal,
mean,
intact.
intact. Okay, what about the general appearance of the patient, like cachexia, any kyphosis, stenosis,
Normal, no,
anything
no specific. No,
specific? Okay, and as you said that there is a wheezing. Which part you said wheezing? Upper part or lower part or all over chest?
all over chest.
Bilateral.
Yes,
Mhm. Okay, and now I need to check the gate. Can you walk for me, Mr. James?
yes. High
Okay,
steppage gait.
high stepping gate. Okay, and what about that
Actually,
Wambach's test?
forget about the gait. It's fine. Normal gait.
Normal gate.
It
Okay,
will be
okay.
complete. Yeah.
Okay, so what about that Rombach test?
What is it? Rombar gait? Normal.
Rombach, yes.
Mm.
Rombach test normal. Okay, so what's your concern, Mr. James?
Doctor, what's wrong with my leg? Why I'm having this severe numbness? Is there any treatment to be given?
Yes, Mr. James, I'm appreciating your concern. So actually, as I feel there is like some numbness in your right foot, mainly up to the your ankle, and it's not related to your upper other side, and you have this rheumatic attack, and you are taking steroid medication. So what I feel actually this is there is a one possibility of that steroid induced, I mean over steroid due to using it can cause this type of the numbness. But I need to do also some blood test, and I need to check your salt test, and also I need to do another study. We are calling it nerve conduction study. I mean to check the nerve function and also your muscle function. And we'll involve our chest doctor for proper control your asthma, and at the same time we will involve our brain doctor to involve
2 minutes left.
like to manage this problem of the numbers. Is it okay for you?
Okay, doctor. But doctor, why this? Why I got this numbness now? I was taking the steroids for the 6 months now, like inhaled steroids and on and off. Why I got
Yes,
it just
actually,
3 days back?
yes, actually there is some few possibilities. I need to do some. Yes, I need to do some blood test. As I said you that it's sometimes associated with your low salt level. I mean there is some salt we are calling calcium and sodium, and sometimes there is some other issues. Even we need to check your some other hormone test. And as I said you some nerve test. And after that actually I can answer you more.
Okay, doctor. Thank you.
Welcome.
Anything
Still
else you
1
want?
minute.
It's another thing it was for me.
Social
Do you have
occupation
any other more
everything.
concern? Yes, social occupational, yes.
Okay. So
Sorry,
it's
sorry,
more.
sorry, sorry. Maybe social. Okay, sorry. I just want to ask you that with whom you are living, Mr. James?
I am living with my wife.
Okay, so you have proper social support.
I'm good supported, no need for support, I'm fine.
Okay, okay. What you doing for living?
Teacher, you asked me
Okay.
doctor before. Yeah.
Yes, yes. Yes. Thank you.
Okay, thank you. You want to start the
Yes,
examiner?
you can ask me. You can
Okay,
ask
can
me.
you present your case?
Actually, Mr. James, 48 years old, he's working as a teacher. Came here to 3 days numbness in the right foot, mainly in the toes area. And he has history of that asthma and recently frequently attacked. He's taking inhaler and nebulizer, and also he's taking now frequently steroid medication. And otherwise, on general examination, I found that vital signs are normal and there is no feature of the lineage of this. There is a widespread wheezing in the bilateral side, and there is a no tummy tenderness, no cardiac issue I found. And also, I don't found there is a spastic or flaccid type of the weakness in the foot or leg or any other parts. And the coordination is also normal. And sensation, I feel there is a sensation impairment up to the right ankle, the right ankle, and also his gait is normal. So I feel there is actually asymmetrical peripheral neuropathy, sensory neuropathy, and it can be that steroid induced and can be associated with the vasculitis. Though I don't found the typical vasculitis feature, I mean skin lesion, joint pain, and weight loss. I don't found, but also there is some possibility of the vasculitis like eosinophilic granulomatosis and polyangiitis, which is related with the asthma. So these are my two differential here.
Okay, any other differentials?
And there is also sometimes some infection related neuropathy can happen. And as I said, that medication induced. And I need to actually, I don't found other feature of that hypothyroidism or vitamin B12 deficiency or diabetic. We don't have history of the diabetes. And I don't found the feature of the inflammatory joint disease like GBS or connective tissue disorder. And he has no other medication history, and I don't found of the feature of the paraneoplastic syndrome. So but I need to do some investigation like EMG and population study and basic blood test, including the electrolyte calcium and level, and also I need to do LC to rule out the vasculitis.
Okay, any more testing you want to do?
Listed basic blood test, electrolyte, calcium, and population study, EMG, and LCA. ENA, we need to do also ENA. So I think these are my tests.
Okay, what's your treatment?
So first of all, that we need to give patient proper education and counseling. If there is any triggering factor, we need to address to avoid it. We need to involve the chest physician, and also we need to involve the neurologist, and also patient as teacher, and there is suffering with his job, so we need to involve social and occupational support. And in this case, we need to start some neuropathic painkiller. I mean, the pregabalin or gabapentin, and also we need to find out any other cause of the peripheral neuropathy and vasculitis for further treatment.
Okay, thank you, Dr. Tanvi.
Actually, little confusing for me, only one foot and only up to the ankle. So it's not going for peripheral
I just
neuropathy properly.
have one question. Why you ignored the Monte Lucas that was started 1 week ago? Like
Like because
nothing came to your
Montelukast,
mind? Yeah.
actually Montelukast associated with vasculitis. I mean, eosinophilic granulomatosis and polyangiitis.
So you are
I
right.
said yes, but I don't correlate with that Montelukast. Yes, but it can exacerbate it.
Yeah, it can exacerbate. And
Yes.
also, he got his asthma just 6 months ago, and he is 40 something years old. So, do you think it's a normal asthma?
No, it's exacerbating asthma. It can be associated with aspergillosis. There is another possibility. We need to rule out actually. Also need to do chest X-ray, pulmonary
Yeah,
function
just X-ray.
test.
Yes.
Yes.
So actually, yeah, this is the case of eosinophilic granulomatosis with cholangitis. Just recently came this diet. The trigger was the start uncontrolled asthma, the start of a new medication, Montelukast, 1 week ago. Okay, so you did well actually, mashallah. But you forgot the travel history. I mean, parasitic infection is also a differential for hypereosinophilia and
Yes. Yes.
asthma and these. So don't forget the travel history. I think otherwise you
Mhm.
covered most of the questions.
Mhm.
I think it was a little bit weird when you asked the numbness. Is it? Do you feel it? I think you said radiating, or you can say any
Yes.
numbness anywhere else. It was a weird question,
Spreading.
honestly.
It's spreading. It's spreading. Yes. Yes.
Yeah, you can ask it in
Spreading.
another way. It was good that you asked about the trauma and the recent infection. You can also ask recent vaccination for GBS. You asked about the diabetes, I think. You can also ask about dietary habits for vitamin B12 deficiency and these the other like dietary causes of peripheral neuropathy.
Mhm.
I think otherwise you did well in the history. In the examination, it was good that you examined the sinuses and the nose, which was very good. I don't have any comments, honestly. You have to, I believe you have to examine the heart sounds, I think. Yes?
Yes. Yes. Heart sound, lung
Yeah.
sound, both I think.
Yes.
So actually, this case is, I think, not typically eosinophilic granulomatosis, vasculitis. It's mainly drug-induced eosinophilic granulomatosis, I think. Is it?
Not
I mean,
drug-induced.
Montelukast induced.
Montelukast exacerbates eosinophilic granulomatosis.
Mhm.
I'm not sure it causes. I don't think it causes, but it exacerbates the
It's
condition.
exaggerated.
So the patient is
Exaggerated.
having,
Yes.
yeah, the patient is having uncontrolled asthma for the past 6 months because of this condition. And now he's been trying multiple medications, inhaled steroids and inhaled, what is it, salmeterol. And now he was started on a new line, which is Montelukast. Once starting
Yes.
Montelukast, he started getting new symptoms of this
Yes.
eosinophilic because it got worse now, which is the numbness.
Yes.
He can also present with foot drop, and you will have to do the full examination of the foot drop
Mhm.
and this stuff. But I wanted to make it
Yes.
easier, yeah.
Yes.
Yes.
And he
No, my
can,
question is here. My question is here. Like here, actually, patient not have typical feature of vasculitis. I mean, no joint swelling, no skin rash, no weight losing, no fever. These are actually combo
yes,
pack of that vasculitis. So I
yes,
found here mostly correlated with Montelukast, with that
yeah,
neuropathy
but
for 3 days.
yeah,
That's why
I
I
gave
feel
you,
that it's not a chronic case.
yeah, I gave you the history of tiredness just to give you a hint of something like
Vascular.
vasculitis. Yeah.
Yes.
But not necessarily to have everything, but you can have, as
Yes,
you
yes.
said, you can have the rash, you can have the joint, fever, weight loss, all. But I didn't want you to think
Yes.
of malignancy or TB. I wanted you to think of vasculitis. Maybe
Yes.
that's why
Yes,
I
yes.
just removed them from, yeah, to make it easier for you.
Which center,
Uh,
Dr. Ryan?
Sorry?
Which center?
Which center? I will check and I will let you know.
But
Okay, I
it
will check.
came.
It
Yeah.
came,
Okay.
this diet it
Oh
came,
my
yeah,
God. Yes.
yeah,
It's a weird case. However,
very weird.
Dr. Tanvir approach, he can get the mark, really.
Yes,
He
yes,
he analyzed everything. He examined everything. Even he
yes.
didn't reach diagnosis because of the weird presentation. I think he can get it. He can get the mark. I mean, from the approach. So
I think
I
so,
I,
yes.
I guess it can be
Or might
a good
only
mark.
lose because he said to the patient the steroid, although the steroid can cause, but usually the steroid will cause proximal myopathy and
Yeah, and the
muscle.
steroid is a treatment, I think, for such.
Yes, it's a treatment. Exactly, you are right. It's the
Yeah,
treatment for the condition.
yeah, it's not as exaggerated or
And
the trigger. Yeah,
yes,
go ahead.
and the
What
close
else?
association of Montelukast with the foot drop is a hint here also. And the uncontrolled
Yes,
asthma, I
yes,
think these are strong hints for the condition.
yes,
So,
yes.
yeah.
I guess also some candidates know the case. They catch the diagnosis.
Yeah,
Very
excellent.
nice.
I wanted actually to write excellent in the
Yeah,
chat
they
box,
did
but
it.
mashallah, yes.
But
Okay.
I believe Dr. Tanvir also did great. He
Yes.
didn't look at the chat box.
Yes.
Really, I appreciate who is candidate participating without looking at the chat box, because this is the time to
Yes.
practice from your own effort.
Yes.
Don't try to read or to distract even. Some doctors are distracted by these comments, and others can reach the diagnosis from the comments. I believe if you want to depend on yourself, don't look at all to the chat box. Test your knowledge from your knowledge, not from the chat box or someone can give you the clue and you can. So I mean, don't read it at all. Ignore the chat box. I don't prevent anyone to write. Anyone can write, okay? But I believe you have to stop looking at the chat box if you are participating, of course. So don't read from the chat box while participating. Either it will distract you and it is not good, or it will help you also, it's not good. So ignore it totally, okay?
Yes.
This is
In the end, this
list, yeah.
practice is not for marks or anything. It's just for
Yes,
us to
test,
improve.
exactly.
Yes.
You're testing yourself. Even you don't know, continue till the end and test your knowledge, how to approach
صح.
without reading or without other help. In the exam, you will be alone. Of course, no one will help you. Unless the examiner are kind, they can give you a clue. But in the exam, you will depend on your knowledge and your approach and your, I mean, how to catch everything in the case or the history taking by yourself. Sometimes you are waiting for volunteer or some surrogate will help you, but not as a rule. Sometimes they are helping, but as a rule, they will not help you. So do that while participating also in this meeting. Don't read from the chat box, which is good from Dr. Tanvir. I believe he didn't read it at all, because if he read, he will mention it. And once he
Yes.
didn't mention, so he didn't read it. Okay, this is regarding the clinical communication skill. The examination, I think he covered all things, but I preferred if he can do dermatomal sensation distribution, Dr. Tanvir. So you can say, is it grossly disturbed, the sensation, or some dermatome? You got it, Dr. Tanvir. This
Yes,
is not
yes,
peripheral neuropathy. This is a
yes,
nerve
yes.
injury. I
Actually,
think
I
this is
asked that when I asked, she said that only the toe, mainly the toe area numbness, and also
exactly.
ankle up to the ankle, because I want to
But
go up, but said
yeah,
up to the
yes.
ankle. After that, it's normal.
Maybe I answered you earlier. I should let you complete.
Yes, yes.
Yeah, but you should do it also in comparison to the other feet or other foot. I mean, the lateral side with the lateral side, medial side with the medial side. Why? Because the common peroneal nerve give the lateral side. I think this is a case of common peroneal injury, right, Dr.
I removed
Ryan?
initially I put it at foot drop, but I removed the foot drop. It's only numbness, like in the end, not full blown peroneal injury.
But I guess it will be single nerve injury, not
Single
as
nerve.
peripheral neuropathy distribution. So it will
Yes, not.
be dermatome or area of distribution, not all foot.
Yes.
So yeah, better to be in this way while presenting. So if you have single area, you have to compare to the other side to know is it related to peripheral neuropathy, but it is not the case because this is asymmetrical. So you have to compare to the other foot to know is it a dermatome distribution or just nerve distribution. In this scenario, yes, mononeuritis multiplex as common peroneal nerve, I believe. So it might affect the lateral side, I mean, of the foot, plus weakness of the eversion, and as Dr. Ryan said, it will be foot drop. This is the difference between peripheral neuropathy and nerve injury. Yeah, yes, I think Dr. Rashid, the case cooked as easy.
Can
Yeah,
be cooked.
yes,
Yeah.
yes, exactly, yes. Yeah, it can be cooked. And we are always cooking the cases to make it easy for each other.
Yeah.
But we should learn on the hard level, not only for the easy level. Try to make it hard because the exam will be much hard by the stress, not only by the case presentation. Okay. Well done, Dr. Tanvir. Thank you for participating today with us. Thank you
I
also,
want to
Dr. Ryan.
add.
Yes,
I
sure,
want to add
sure.
a
Yeah.
little in the investigation.
Go ahead.
So,
Sure, sure. Go ahead.
so full blood count. Don't forget to mention for eosinophilia. It's
Yes,
important. They
exactly.
might ask you.
Mm.
And IgE levels, inflammatory markers,
Mhm.
ESR, CRP, urinalysis
Yes.
and microscopy. Don't forget because they can have renal involvement. Chest X-ray, HRCT, sinus CT, sinuses. Don't forget. Spirometry also. If not done before, they will need spirometry. Sometimes if the chest x-ray or the imaging, whatever you did, HRCT for example, showed pulmonary infiltrates, you might need to do bronchoalveolar lavage to rule out alveolar hemorrhage and malignancy. So just say at the end, consider, not do, consider.
Yes.
Now we have to do also investigations or consider investigations for the complications. These patients are at high risk of
Perfect.
cardiac problems.
Yes.
So myocardial infarction. So consider troponin, BMP, ECG, and echo. And also sometimes cardiac MRI for eosinophilic infiltration. So also consider, don't forget. Glomerular disease also. So we said we will do urine microscopy. If there is any GI involvement, so the patient is having any like blood or dark stool or like depending on symptoms, then we do GI testing by upper or lower endoscopy. And for the nerve, the peripheral or the nerve issue, we do, as you said, nerve conduction study and EMG. Biopsy is not usually done, but sometimes can be done if not reach the diagnosis. Biopsy of the nerve.
Perfect.
Okay. With
Yes.
regards to the treatment, so the first line treatment is high dose steroids. Sometimes the steroids can be combined with other treatment like cyclophosphamide, for example, if there is
Kidney affection.
high severe disease. There is actually scoring system for the disease. I forgot what was. I think factor something.
Mhm.
Anyways, no need. But مهم يعني steroids first line with
Biological.
cyclophosphamide. Yes,
Any
there is
role of biological? Yeah.
Yes,
Go
there is
ahead.
biological treatment called mepolizumab, which is antagonist for IL-5, but this is used for mild disease, not for severe disease. For severe disease, we have to use cyclophosphamide with or rituximab, I think. So cyclophosphamide,
Yes.
I will check the other one. I think rituximab. But this
Yes,
mepolizumab, the biologic, is not used for severe disease. Okay, don't
I
forget
think
also the supportive measures, the splint for the leg, and you said the neuropathic pain and physiotherapy. Also, very important thing is vaccinations for these patients. COVID vaccine, influenza vaccine are very important.
Dr. Ryan, I want to add something.
Yes.
In vasculitis, I have seen if you do not know any exact name of the biological agent, always you can put rituximab because in most of the cases, you see it's written in the books that we can use
Yes.
rituximab.
Yes, you are
And
right.
if anybody asks for the differential, we can put peripheral neuropathy, but peripheral neuropathy it should be bilateral like this.
Yes, I
And
think we can put
that
other differentials with mononeuritis multiplex also.
yes,
Like
like diabetes.
microscopic. We can put microscopic polyangiitis can cause also mononeuritis multiplex, granulomatosis with polyangiitis,
Yes,
polyarthritis nodosa. We can put viral causes, leprosy, for example, can cause only sensory in one side. We can, I think that, yeah, we can, as you said, we can put peripheral like vitamin B12 deficiency, but you say against that,
yes.
it will, whatever is against that, yeah.
Only
So
arthritis
you
nodosa
can
can
also
be as a differential.
Polyarthritis nodosa,
Can?
yes, can also cause mononeuritis multiplex, but
Mhm.
polyarthritis nodosa is usually associated with hepatitis B infection and
Mhm.
sometimes testicular pain.
Yes, yes,
Uh,
exactly, yes.
yeah.
Yes, if we change
Cryoglobulinemia.
polyarthritis nodosa,
Sorry?
yes, yes, for polyarthritis nodosa, as you said, that is actually almost head to toe. Everywhere there is a problem.
Yes,
Yeah,
yes,
Like it
yes,
can
yes,
even involve the abdomen, testes, the
yes,
stimulation,
yes.
the foot, and everywhere actually. So
yes.
mostly
Cryoglobulinemia
widespread.
also. Cryoglobulinemia. This is, but if I think it will be associated with kidney, not only neuropathy.
Yes.
We can also put common peroneal nerve because in common peroneal nerve there's a loss of dorsiflexion and eversion, and also we can put L5S1. In
Yes.
L5S1, there's a loss, weakness of dorsiflexion and
The
inversion.
radiculopathy. Yes.
Radiculopathy, yes. I want to add one more thing also. These patients usually will have the steroid treatment for a long time, I think months. So they say sometimes they suggest PCB prophylaxis because they will be on high dose steroid. So just to keep it in mind.
What prophylaxis?
PCB, pneumocystis, because they will be on high dose
Yes,
of
yes,
steroid for a long time
yes,
with immunosuppressive
yes, yes,
therapy. So
yes, yes.
PCB prophylaxis. Don't forget the vaccination, COVID, pneumococcus, and influenza.
Very nice. Today, both cases were very nice cases today.
Thank you,
Yes.
Dr. Azhar.
We
Thank you,
learned
Dr.
a
Ryan.
lot.
Very nice. Yes.
I was thinking that Dr. Rayan, she's always having thyroid. So today there was no
I,
problem with the
I
thyroid.
changed, see?
She changed her career now.
She
Next time
came
I
a
will
little
give you
bit low.
something else, Dr.
Uh,
Azhar.
She came little bit low from thyroid to chest. Next
yeah.
time she will bring some tummy case. No, mashallah, cases was very good. Prince
Yeah.
Proud.
Nice,
Thank
Very,
nice
you.
very good.
preparation for the case, Dr. Ryan. Thank you so much.
Thank
A good
you.
question also from Dr. Tanvir about trauma. It's very important to ask about trauma in any asymmetrical presentation, neurological, I mean, either weakness or numbness. So you have to rule out trauma. In some cases, like peroneal trauma or trauma to the lateral side of the thigh or the knee, it will cause peroneal nerve injury as a foot drop, either trauma or cast compression over the nerve. So it can be as a differential. Common peroneal nerve palsy or nerve injury, it can be as a differential, particularly in this case. But against that, you will say no trauma or no injury to this area. I guess we cover most of the topic. The differential, the
Dr. Basma,
gastric. Yes,
uh,
go ahead.
regarding common peroneal nerve, one case came in the exam. Patient
Uh-huh.
said, when I wake up in the morning, I have weakness of my right foot and leg.
Good. Yeah.
So the history was that before sleeping, he hit his knee with the bedside.
Okay.
When the history of trauma was
Yeah.
taken, the surrogate told that before sleeping, I hit my knee with my bedside.
Perfect. Yes.
So
That's
this was a clear case of common peroneal
perfect.
nerve due to trauma.
Perfect. Perfect. That's why I prefer to ask about the alarming signs for any neurological presentation, weakness or numbness. You have to ask about the neurological, as Dr. Tanvir did, and any trauma. So the neurological, any loss of control over your bowel or water work, or any back trauma or back pain, and any trauma to particular area of the presenting complaint. You have to check this question while analyzing for the numbness. Okay, great case. As usual, Dr. Ryan, thank you so much, and Dr. Tanvir as well. Thank you for the comments. I think check for Bianca. Yes, I think we have to do Bianca here.
Yes,
I
Priyanka.
think
Yeah, I
Bianca, yes.
forgot to mention it. Yes,
Yes,
Bianca.
perfect.
Priyanka.
We
Thank
have,
you.
if we
Priyanka.
forget always, we have awake participants. They are writing. Really, I really thank all of you for your comments. Although you are not sharing verbal comments, but your comments always complimentary. So what we
Yes.
miss, they are writing. Like Bianca, roll out renal involvement, of course. Common perennial nerve, yes. GI protection, bone protection for steroid. You have to mention for any steroid, not only this case. Any patient with long-term steroid, you have to mention this medication. He high steppage gait, yes, of course. Foot drop not cause normal gait. No, foot drop will cause no, it will cause
High
high
steppage, high
steppage.
steppage
Yeah,
gait,
she
yes.
want to make it easy for you not to be distracted. But anyway, you catch the case
Yeah.
later on, Doctor.
I think this case
Uh,
was in Lahore, I think, on the 22nd of this month. So just
fresh
fresh
case.
one,
Good.
yes.
Yeah. Thank you, Dr. Ryan. Really,
Thank
I
you.
appreciate the effort to bring fresh scenarios because the fresh scenarios comes in the coming diet before it will
Yeah.
be known to us. So they are trying to bring fresh scenarios. If you catch these
Yes.
scenarios, yes, they will bring it maybe to the next diet or maybe before that you expect. So I prefer to bring fresh scenarios. Late onset of asthma worsening. Thank you, Dr. Zainab. Uncontrolled asthma worsening after multiplex with mononeuritis multiplex, eosinophilic, yes. Granulomatosis cholangitis. By the way, it's not Charles-Strauss anymore. Try to mention the eosinophilic GPA or EGPA, eosinophilic granulomatosis cholangitis, not Charles-Strauss. Or you can say formally named as Charles-Strauss. Yeah, I think we cover all questions and comments. Okay. Any question by others?
Hello. Hi.
Yes, Dr. Dalia.
Hello. Yeah,
How are
nice
you?
test, nice
Yes.
presentation.
Yeah, go ahead.
Yeah, I want to add something. They might change the scenario from as uncontrolled asthma to chest pain or shortness of breath because the main for it's there is a case study about the leukotrienes an antagonist trigger myocarditis in patient with vasculitis with Church stress or eosinophilic with granulomatosis. So if they change that, because I'm feeling that it's unfair to bring such a case to the exam, but if they this is the this is the trend right now, so just if they change that to chest pain with shortness of breath when like one limb like yeah, I mean like mononeuritis multiplex, whatever, it's cranial nerves, it's the peripheral nerves, whatever. So if there is such a case similar but with chest pain or shortness of breath, just think about myocarditis, and this is the major risk for it's life threatening could be. Okay, so just put that in your mind, myocarditis or my cardiomyopathy. And don't forget that the anemia, blood, because it causes bleeding from the GIT, ischemic pain, like vasculitis everywhere. Okay, just screen for melena or okay, and symptoms of anemia with such case. Thank you.
Thank you, Dr. Dalia. Always your comments as precious. I think it's unfair, really, to bring such case myocarditis
It's
related to.
unfair.
Yeah, but anyway,
This
yeah,
is, a case studies. This is, you know,
mhm,
it's
yeah,
not really frequent. Okay. And they postulated that it's because of, the leukotrienes should block it to block an eosinophil. Okay. To decrease the number of eosinophil that activated during asthma. So, with high dose of steroid of exacerbation of asthma, uh, cause a paradoxical effect and increase the eosinophil and make the vasculitis worse. This is really, you know, this is really because it's confusing, yeah. So electrotrienes block the eosinophil, okay, but to decrease the inflammation of asthma, okay? But in such case, with high dose of steroid to treat the asthma, and then the leukotrienes, this will induce paradoxical effect on eosinophil, increase the number, and trigger the vasculitis. This is a postulation about that. And this is unfair. I'm not happy.
yeah, you're right, doctor.
Okay.
But again, any vasculitis, you can think the clots related to vasculitis or the effect of vasculitis on certain organ, you can put it as differential. If you don't find the explanation,
Yeah.
put as
Just
vasculitis. Yeah,
yeah.
especially,
Yeah. Just
especially
put.
with B symptoms.
Yeah, I guess if they want to be fair, if you just put the differential of exacerbation of asthma and uncontrolled asthma, vasculitis, one of your differential, the candidate did well actually. So this is the most you need to do. Okay, otherwise, the details, the diagnosis, I guess this is not, this is not the
Yeah,
mainstay of this
yes,
case.
exactly.
Okay,
Yeah, yeah,
so just like advice, any patient has high temperature, loss of weight, mononeuritis multiplex,
exactly.
think
Yes,
of vasculitis.
exactly.
Okay,
Also,
weight
skin
loss,
is,
high
yes,
temperature is similar to endocarditis. When you think of
similar.
endocarditis, think of
Yeah,
vasculitis. And when you think of vasculitis, you need to put is it vasculitis per se or vasculitis secondary to malignancy? And put that in your differential as well, okay?
yes, yes.
Okay,
Plus
thanks.
the rash, Dr. Dalia, livido reticularis, one of the associated rash or skin change. Don't say rash. It might be for the patient, not rash. So
Yeah.
you can ask about any skin change.
Yeah, if it's like joint pain, it will be easier. I'm not sure this
Yeah,
case has joint pain or something. Okay, but not all cases with shrimp. But
exactly. Not,
most
yes.
cases with they came with it could be with Raynaud, it could be with rash, it
Mhm.
could be with mononeuritis, and most common admitted patient come with mononeuritis multiplex. Okay,
Yes, thank you, Dr.
thanks.
Dalia.
Bye.
Thank you so
Thanks.
much.
Bye.
Any
Dr.
question or
Basu,
comment? Yes, go ahead, Dr. Azhar.
this multi-lupus actually aggravate this mononeuritis or asthma? It's the
It's
aggravating factor for what?
you mean related to our case today? No,
But
it's
yes.
For the
no.
condition,
It's
what I know,
aggravating.
Dr. Azhar, for the condition,
Uh-huh.
so the mononeuritis multiplex is
For
part of the EGPA. So
Okay.
Montelukast is a trigger
yeah,
for the whole condition.
yeah, as a eosinophilic, yes, eosinophilic granulomatosis polyangiitis. So it exaggerates the whole
The
vasculitis
condition,
condition.
yeah.
Yes, not
And
related
Mm.
to the nerve itself. It's
yes,
not related to the main
the
nerve
nerve
itself.
issue is part of the whole disease.
Eosinophilic, yes, exactly.
Yes,
Whole
yes.
disease. But it's a treatment in advanced stage of asthma. Now, they changed that stepwise manage for asthma. You know, Dr. Asa? It's the guidelines
Yes.
changed now. It's not as before SABA as a first line. They are starting now with the MART. So
Yes,
steroid as inhaled, mild dose will be given at the beginning with salmeterol. This is first step.
Okay.
Then you
Can
will
you
add,
share? Can you share the
yeah,
guidelines?
as
I do
both
not know.
rescue and
yes, exactly.
maintenance, Dr. Basim, صح?
Yes, as maintenance, not for asthma exacerbation. I'm talking about maintenance. For
Mm.
exacerbation, the same steroid and back-to-back nebulizer, and detect what level you have, either asthma, life-threatening, consider intubation, and so on. Anyway, if you have presentation with acute, you have to mention ABCD approach. If you don't, go to the maintenance, and I will post the guidelines for the maintenance. It's changed now, no more SABA at the beginning. But still LATRA, one of the management, I think step three, lateral, which is Montelocast, or step four. I will post the guidelines now after the
Okay,
meeting.
it's the first step now is air therapy. Is
Yeah,
abbreviated
Mart.
like air therapy,
Yeah,
not MARTS.
before Mart.
Yeah, the first one is air therapy. The second one is MARTS.
Okay.
Okay.
Yeah,
Is the second step is MARTS with low dose, then medium dose, then yeah,
exactly. Yes, mild, moderate, and high
yeah.
dose. Yes.
Okay.
Thank you, Dr. Tali. Thank you. Yes, Dr. Zainab wrote it aggravate the asthma in EGP. Yes, that's why you have to know what type of asthma you have. Sometimes if patient having asthma resistant to the usual management, they are doing advanced investigation like eosinophilic count and IgE. You should know if this patient is having such kind of asthma or not before offering Montelukast. I think that's why the patient has exaggeration. But since you have eosinophilic type, you can think about the lines for vasculitis rather than the asthma management itself.
Okay.
Okay.
Just a reminder or a question for the
Mhm.
candidate.
Yeah.
He said about the After she said she's struggling a lot with her, he's struggling a lot with her symptoms of asthma with his work as a teacher. He offered to refer him to occupational department. Yes.
Yes,
Yeah,
exactly,
he
Dr.
mentioned
Yeah.
that. Yeah, this
Mhm.
could. Yeah. Why you want to refer him to occupational health department, doctor?
Dr. Tanvir,
They ask you.
Dr. Tanvir, I think he might left. I don't know.
Okay.
Maybe he left, yes. But you're
Okay.
right, Doctor, yes.
Yeah. There is no need here for referral.
Mhm.
Okay. So just in case, because Dr. Basim, you are here. Okay.
Mhm.
There is two candidate has failed the exam because of such referral. Please be careful. Okay.
Okay. And
Okay.
the
So
justification is
yeah.
no need?
So yeah. Yeah. In a Sharga or Ajman center,
Okay.
they failed to candidate because they do referral for occupational health department without indication, and they went
Oh
in
my
the
God.
long conversation about what the role of occupational health
Oh,
department. At
yeah.
the end,
They become
they know that he
irritated.
just
Yeah.
got irritated because
Mm.
they feel that the candidate didn't know about anything and just do
Yeah. So
referral.
he's saying, yeah, yeah. Okay. Yeah,
Okay.
we have to be careful about that. Yes.
Careful whenever there is any if there is any permanent disability or there is
Hmm.
chronic disease
Yes.
that
Illness. Yeah.
affected by the job itself, they could
Yes.
refer the patient. Otherwise is got irritated the examiner, and they, because here if you want to apply for a job, if they don't have good referral system, no, this is will be very annoying. And it's one of the, the reference from your consultant is that does the doctor do good referral or no. So this is a major thing here. So please, 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 if anyone during the sessions do wrong referral for the occupational health department, please just remind him this is not yeah, there's not indication, don't refer. It's, for
Okay, I
example,
got your point.
okay,
Yeah, but the
so
thing is, if you are doing well in communication, exams, and identifying physical signs, clinical judgment, differential, so only single this mistake, they will fail. Only this.
it happened that it's for the whole conversation they went to discuss about occupational health department, that it's and I know one of the candidate herself that she went in the clinical case, by the way, she put her stethoscope in a weird area, not in the apex, on the apex, okay, and they failed her on the exam. I met her personally, and they failed her in the exam. And we went together to practice together one day. And I just, she said they just asked about the surface anatomy, and the whole exam just about the surface anatomy of the heart. Okay. And the end they failed hard because they didn't even ask her about, yeah, the usual question. Okay. Sometimes if you do something very unacceptable for them, I don't know it's fair or unfair, but they could do that. And when I went for practice with her, she put the stethoscope haphazardly. At that time I just realized why the examiner failed her. She just put without see where the stethoscope,
Without looking. Yeah, just putting.
okay,
Yeah.
just put the stethoscope. And when I look at it, in the seventh intercostal space with the anterior axillary line, and this is the fairest, even she didn't look for the apical pit, and this sometimes if you do something for them according to their perception of the kind of mistake, they got annoyed. Okay. So just don't do referrer. That is, it's just be
Unnecessarily.
careful, unnecessary.
Yeah.
The
Yeah.
occupational health department is, for example, if the patient, for example, on insulin and the night shift make his for example, his disease is uncontrolled and need to, they could change the the shift from night to morning. And if, for example, there is a pregnant lady or the mother that he couldn't come early every day from 8 o'clock in the morning up to 5, and she could just manage to come for 8:30 in the morning, they could manage this. Occupational health department could manage her, is has the period of working. Sometimes they took from the lunch break. Sometimes they put another 30 minutes at the end of the day. So they sometimes do something really just for the shifts, for the work, some modification for the shift or work, or some disability if the is typer or pianist or anything, like any job that needs. And I know one of the consultant has problem. She has rheumatoid arthritis and she has a deformity, and the occupational health department offer her some kind of apps to do verbal, because the documentation all the day on the computer, to do notes and to do referral and to do. They just put her in the, some kind of application or software, program, to do the notes,
Mhm.
verbal
Yeah.
notes, and it's
Dictation,
this
like
kind of
dictation.
things,
Yeah.
so
Yes.
kind of things. If there is
Mm.
a firefighter exposed
Dictation,
to
exactly.
dust,
Yes.
or yeah. I mean that kind of things. It's something related to the job, to the shift, to the disability,
Yeah.
to the something is chronic and permanent.
So in
Okay.
summary, Dr. Dalia, don't call them unless it need. Or in another way, don't offer them unless they will ask you what to do, doctor. I cannot do my job. To be sorry, it's fair enough for the situation. If you ask
Yeah.
how is that affecting your job,
Give.
I'm so sorry, for example, I'm so sorry for your suffering. I will try to help you in this. That's it. Don't
Yeah,
mention
and
either
you
occupational
could
or
give,
other.
yeah,
Yeah.
sick leave. You are,
Yes,
yeah,
exactly. Sick leave, it's available. You can give it. Yes,
yeah,
exactly. This is the best and the maximum offer from our side. Don't exceed this limit because you are not authorized to call for occupational, and no need to put yourself in a trouble with the examiner. Yes, I believe. Yes, some examiner when they got irritated, they will fail you whatever you did. Especially they will go with the discussion away from the case, like Dr. Daria said. He will discuss with you when you call for occupational, and he will make all this like sarcastic discussion. But at the
yeah,
end, you will feel bad and he will fail you. So
yeah,
don't offer something which is
yeah. You could,
unnecessary.
you could
Mm.
say, I will do my best to help you. This is a
Exactly.
good
That's it.
sentence
Yeah. Yeah.
to do inside case.
I
And if
believe this is the
someone
way.
ask
Yes.
about occupational therapist and the occupational health department, yes, it's separate terms.
Yes.
Occupational
Yes.
therapist is a kind of
For disability.
physiotherapist. Yeah, it's a branch, like they like in their colleague, that is a subspecialty of kind of physiotherapist, but they are
Mhm.
specialized on the home,
Arrangements. Yeah.
arrangement, rails, elevators, some kind of.
Wheelchair.
Sometimes they will look
Exactly.
at them. Yeah, they will look for the kitchen if the worktop is high for the candidate, for the patient, or low, or they will do modification in the house.
Yeah.
They will give any kind of tools,
But
many
it will
things like
be with a neurology case. Clear and straightforward. This type of occupational therapist
urology,
usually,
arthritis, by the way,
yeah,
and
rheumatology or neurology, not more
this.
than this.
Yeah, it's a home, yeah, home
Exactly.
based, yeah, okay, home based things,
Yeah,
mobility, and daily living stuff,
exactly. Any
how to
disability,
to yeah to improve the independency while the patient at home,
Yes.
and the mobility.
Yes, how to cope with your daily activity
Yes.
if you have some disability.
Yeah, you could think of different kind of stuff. Okay.
Yes, yes, yes. Thank you, Dr. Dalia.
Yeah. Thanks.
Very nice way to clarify this issue.
Thanks.
And yes, as advice, please don't mention the team which you are not aware about their task unnecessarily. Keep it as simple as possible. Don't tell the patient, I will refer you to occupational, they will help. What the benefit of that? Just tell him, we will do our best to help you. Okay, fair enough to that, and they will respect your answer. But if you mention a team unnecessarily, they will think you are saying anything for nothing needed. Okay, thank you, Dr. Dalia, again for the comment and for the attendance for all of you participants. Thank you, Dr. Tanvir, Dr. Ryan, particularly for practicing today. Again, I encourage everyone, any opportunity to practice here, it will help you not to have the case in the exam. Better to practice it in this meeting particularly, or other meeting, I mean. But if you have opportunity, do it. Okay? Anyone interested, he can message me privately. Thank you, everyone. Any question before ending the session? Thank you, Dr. Najat, for the comment, occupational, and yes, Dr. Dalia already mentioned. Thank you, everyone. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.